Imagine for a second you have a mosquito bite. Or maybe just, a random annoying itch on your arm.
Right, something totally normal.
Exactly. And you do what anyone would do. You just reach over and you scratch it. Usually the skin gets a little red, maybe it swells for a few minutes, and then it just goes back to normal.
Because the healing process is, well, it's completely predictable.
Right. But I want you to picture a scenario where that simple everyday act of scratching an itch, or even just like the friction from wearing a tight piece of clothing, doesn't just cause temporary redness.
Yeah, where it does something much more extreme.
Imagine if that minor physical scrape acted like a highly specific biological command code, basically instructing your immune system to build a chronic, tissue-altering disease right in that exact spot.
It's wild because it completely upends our fundamental understanding of how the body is supposed to heal.
I mean, you expect your immune system to repair a scratch, right?
Yeah.
Not use the open wound as like a construction site for a chronic illness.
Exactly. It's a total hijack of the system.
And that bizarre medical quirk is exactly what we are focusing on today. Welcome to the Deep Dive. Today, we are digging into a stack of clinical guidelines, dermatological research papers, and NHS trust documents to unpack something called the Koebner phenomenon.
And it's a fascinating phenomenon to look into.
It really is. And we're going to explore this through the lens of a very specific, frequently misunderstood condition called lichen sclerosus. Our mission here is to look at how the body's natural healing mechanisms can sometimes get just completely hijacked.
Right, and what it actually means to live in a body where the basic physics of existing, just moving around become a trigger for disease.
So let's unpack this. What exactly is the Koebner phenomenon?
So what we're really looking at here is a profound communication breakdown between the outside environment, so the physical friction your skin experiences, and your internal immune system. The term is actually named after Heinrich Koebner. He was a 19th century dermatologist who first documented this incredibly specific response. But the crucial thing to understand right off the bat is that it isn't a disease in and of itself.
Wait, so you don't catch the Koebner phenomenon?
No, not at all. It is a hyperactive, localized response mechanism. It only occurs in people who already have certain underlying systemic conditions.
So it's basically a reaction style.
Exactly. It's a very specific way your body chooses to panic if you already have something else circulating in your system. The sources detail how this happens across a bunch of distinct dermatological conditions.
Like what? What's an example?
Take patients with psoriasis, for instance. That's an immune-mediated genetic skin disease characterized by these red, scaly patches with silvery white edges.
Right. Pretty common.
Yeah, very common. Now, if a patient with psoriasis cuts themselves while, say, slicing an onion, or they scrape their knee on the pavement, or even just get a sunburn, they won't just heal with a normal scab.
They won't.
No. The Koebner response dictates that a brand new psoriatic plaque will form exactly along the physical lines of that cut or burn.
Okay, wait. So if I have one of these conditions and I scrape my knee, my body doesn't send in the normal platelets to build a scab.
Nope.
It's like my immune system sees the open window and accidentally, downloads the systemic scare condition into that localized spot.
That is actually a highly effective way to visualize it. You're downloading the systemic disease into a localized folder.
Wow.
The trauma acts as a highly specific trigger for an immune overreaction. We also see it in vitiligo, which is an autoimmune condition where the body attacks its own pigment-producing cell.
Oh, I've heard of that.
Right. And a physical blow or a scrape can precipitate brand new white depigmented spots right at the exact site of the injury.
That's incredible.
Or in lichen planus, which presents as these purplish, itchy spots. The lesions will literally appear in a straight, geometric line, tracing exactly where the person scratched their skin.
The idea that your own fingernails can basically draw a map for where a disease should appear is just wild to me.
It is, and it actually goes far beyond just minor scrapes and scratches. The medical literature in our sources notes some truly astonishing examples involving major surgeries.
So the surgery itself becomes the trigger.
Exactly. The attempt to fix one problem creates a devastating Koebner response. There's a case series in the papers documenting patients who underwent hair transplants.
Oh, wow. Getting a hair transplant, that seems like a massive amount of microtrauma to the scalp.
It is a huge amount of trauma. And for some patients with an underlying susceptibility, that surgical trauma triggered the Koebner phenomenon.
So what happened?
Several patients developed a severe inflammatory disorder that causes permanent scarring and hair loss directly after the transplant.
Oh, you have got to be kidding me.
Yeah. The trauma of inserting the hair follicles cause the immune system to attack and scar those very same follicles.
That is the ultimate cruel irony. You endure the pain and the cost of a transplant to get hair, and the trauma of the procedure basically guarantees you lose it permanently.
It's awful.
Why would the immune system even do that?
Well, the prevailing theory centers on something called immune privilege. Hair follicles normally exist in a state of immune privilege,
Meaning what, exactly?
meaning they have a sort of biological invisibility cloak that hides them from the body's immune cells. But when the surgeon makes thousands of tiny incisions to implant the hair, that trauma shatters the invisibility cloak.
So the immune system suddenly sees them.
Yes. Suddenly sees these follicles, doesn't recognize them, and launches an all-out autoimmune attack to destroy them.
That is terrifying.
It happens in other surgeries, too. The same source outlines cases where patients developed a variant of alopecia that attacks the frontal hairline, specifically following cosmetic facelift surgeries.
After a facelift.
Yeah, the incisions from the facelift cracked open the cells, spilling their internal contents or antigens, and that alerted the immune system to attack the surrounding tissue.
Okay, so if the immune system is misfiring like this over surgical incisions and scrapes, what happens when this biological glitch collides with a condition where the entire premise of the disease makes you want to scratch your own skin off?
And that is exactly what brings us to the main focus of these clinical papers, lichen sclerosus.
Let's get into it.
So, to understand the gravity of that collision, we first need to look at the canvas the Koebner phenomenon is acting upon. Lichen sclerosus, or LS, is heavily misunderstood.
Yeah, the sources made a point to clear up a lot of myths right away.
We really should clear those up first.
Mhm.
It is not an infection. It is absolutely not contagious. It cannot be passed to a sexual partner.
Right, not an STI.
Correct. It is not a sexually transmitted disease, and it is not caused by poor hygiene.
Which I imagine must be a massive relief for patients who are terrified they've caught something or done something wrong. But if it's not a bug, the medical consensus points to it being an autoimmune condition. Right, similar to the psoriasis and vitiligo examples.
That's right. The immune system is essentially misidentifying the skin tissues and attacking them. The sources show LS frequently occurs alongside other known autoimmune diseases.
It's like they travel in packs.
They do. Patients with LS have a statistically higher incidence of thyroid disease, type 1 diabetes, vitiligo, and alopecia. It's really part of a broader immune system misfiring.
Let's talk about the demographics and the visual reality of this, because the clinical descriptions in these dermatological atlases paint a very specific picture of who gets this and how it alters the skin.
It's most common in women, outnumbering men about 6 to 1.
Or even 10 to 1, according to some estimates I saw in the papers.
Yeah, it depends on the study. And in females, it peeps at 2 distinct times in life. First, in prepubertal girls, sometimes as young as 3 to 5 years old.
Which is heartbreaking.
It really is. And then there's a much larger peak in postmenopausal women. But it absolutely affects men as well.
Right, but there's a specific subset of men it affects mostly, right?
Yes, almost exclusively those who are uncircumcised.
Okay. And what are the visual markers?
They're very striking. The classic description is a porcelain white or ivory-colored patch. The skin loses its pigment, it takes on a very shiny appearance, and as the chronic inflammation damages the structural integrity of the skin, the top layer severely thins out.
The sources describe the surface of these spots as looking like wrinkled tissue paper.
Wrinkled tissue paper, exactly.
That sounds so incredibly fragile. I'm picturing skin that could tear if you just move the wrong way.
The skin fragility is profound.
Yeah.
Now, LS can appear on parts of the body, like the bends of the wrists, the upper trunk, around the breasts, or the neck.
But from what I read, those patches on the wrist or neck mostly just sit there. They don't typically hurt or even itch that much, which I guess is a blessing.
True. Extragenital LS is usually entirely asymptomatic.
Yeah.
The vast majority of LS, however, attacks the anogenital areas, and down there it is fiercely symptomatic.
And here is where it gets really interesting. Because this is the exact intersection where the Koebner phenomenon turns a difficult skin condition into a vicious, self-perpetuating cycle.
Precisely. Because the defining, maddening symptom of genital lichen sclerosus is severe, intractable itching.
The sources talk about itching so intense that it wakes patients up from a dead sleep. Itching that makes sitting in a chair or walking around a grocery store socially incapacitating.
Which forces the patient into a devastating feedback loop. The patient experiences this overwhelming itch, so they inevitably scratch.
Which creates trauma.
Yes, the scratching creates physical friction and microtrauma on that incredibly fragile tissue paper skin. And because of the Koebner phenomenon, that exact physical scratching actively induces brand new lichen sclerosus lesions.
Your body is literally screaming at you to scratch an itch, but the physical act of scratching is the exact trigger that feeds the disease.
It's a cruel paradox.
It's like trying to fix a glitching computer by violently smashing the keyboard. You're just writing more broken code into the system. Every time a patient tries to find relief, they're basically commanding their immune system to lay down more disease.
That's a perfect analogy. The initial inflammation causes the itch, the scratching causes the trauma, the Koebner response translates that trauma into more inflammation, which causes more itching.
And the trigger doesn't even require fingernails, does it?
No, not at all. The Koebner response in genital LS is so highly sensitive that everyday friction acts as a biological command.
Like what kind of friction?
Tight underwear, rubbing against the skin, riding a bicycle, horseback riding, sexual intercourse. Any of these provide enough physical friction to activate the skin and spread the disease.
Wow.
Even the use of panty liners in women can create enough microfriction to worsen the condition over time.
The sources brought up something I hadn't considered at all, which is chemical irritation acting as a trigger alongside physical friction, specifically the role of urine.
Yes, that's a major factor.
How does fluid trigger a mechanical response?
This is a critical point, particularly regarding male genital lichen sclerosus.
Yeah.
The disease almost never occurs in men who were circumcised early in life.
Right.
The prevailing theory for why uncircumcised men develop it hinges on the concept of occlusion, meaning trapping and microincontinence.
Okay, break that down for me.
Well, after a man uses the restroom, a microscopic drop of urine might remain. In a circumcised male, that drop has negligible contact with the skin before being absorbed.
Makes sense.
But in an uncircumcised male, that drop becomes trapped between the tightly opposed mucosal surfaces of the foreskin and the head of the penis. Over years and decades, this trapped urine acts as a constant, low-grade chemical irritant.
Which basically confuses the local immune cells.
Exactly. This chronic irritation, coupled with the natural friction of the foreskin, triggers the Koebner response.
And the same principle applies to women with urinary incontinence, right? The constant exposure to moisture and the chemical makeup of urine irritates the skin.
Yes, signaling the local immune system to wake up, which triggers that Koebner response and feeds the cycle.
So we have this perfect storm. You've got fragile, thinning skin, an insatiable itch, and an immune system that uses every scratch, every rub of tight clothing, and every drop of trapped moisture to build more disease.
It is relentless.
If this vicious cycle runs unchecked for years, what is the actual physical fallout for the patient?
The anatomical fallout is severe. It's driven by the repeated breakdown and disordered healing of the skin. When the skin is constantly inflamed and provoked, it stops healing normally.
What does it do instead?
It begins to form dense scar tissue, and this scarring leads to profound, permanent structural changes. In women, the intense inflammation often creates a figure-of-8 pattern of white, scarred tissue looping around the vulva and the anus.
The sources had some really tough descriptions of this part.
Yeah, as the disease progresses, the inner lips of the vulva can actually adhere to one another. Over time, they can fuse completely and essentially disappear, blending entirely into the surrounding skin.
The tissue literally fuses together and just erases the normal anatomy.
Yes. Furthermore, the hood of the clitoris can scar over, eventually burying the clitoris entirely. The opening to the vagina itself can narrow significantly, and in end-stage, untreated disease, it can close over almost completely.
The physical reality of that is just staggering.
It is deeply traumatic.
And for men, it mostly attacks the foreskin, right?
Right. The chronic inflammation and scarring cause the foreskin to become incredibly tight and inelastic. It gets to a point where it can no longer be retracted.
Oh, wow.
The scarring creates a rigid, fibrotic ring that draws in around the shaft of the penis. Visually, it looks like a tight band or a belt squeezing the tissue.
That sounds incredibly painful.
It is. The thinning of the skin and the loss of elasticity mean that normal physiological functions become intensely painful. Patients experience severe pain during sexual intercourse because the scarred tissues simply tear and bleed under tension.
Because it's literally like tissue paper tearing.
Exactly. The skin splits, creating deep cracks that easily become infected with bacteria or yeast.
So the basic bodily functions we all just take for granted become an absolute ordeal. I read in the sources that if the skin around the urethra or the anus is involved, even going to the bathroom is agonizing.
Yes. Severe constipation, especially in children, is really common because the skin is too scarred and tight to allow for a normal bowel movement without excruciating pain.
Beyond the immediate destruction of quality of life, which is huge, we have to look at the long-term systemic risks of leaving this cycle unbroken, because there's a very serious oncological risk.
Yes, there is. Chronic, untreated, inflamed lichen sclerosus in the anogenital region carries approximately a 5% risk of transforming into a type of skin cancer.
Wait, 5%? That is a massive number when we're talking about cancer. Why does an autoimmune disease suddenly turn into a malignancy?
It essentially comes down to cellular exhaustion. Because of the Koebner phenomenon, the skin is in a constant state of tearing, inflammation, and hyperactive repair. Every single time a skin cell divides to repair a tear, it has to copy its DNA.
Right, basic biology.
But the more frequently cells are forced to divide and repair in a chaotic, highly inflamed environment, the higher the mathematical probability that a mistake like a typo will occur during that DNA copying process.
Oh, I see.
Yeah. If a critical typo takes hold, that cell mutates and becomes cancerous. It usually presents as a new nodule, a persistent ulcer, or a thickened area on top of the already white, scarred tissue.
We really have to pause and reflect on the absolute severity of this. I mean, if the mere act of living, walking, wearing clothes, using the bathroom causes friction that makes the disease worse, how is it even possible to stop this cycle?
It's incredibly difficult.
How do you treat a disease that basically feeds on the basic physics of existing?
It requires a highly disciplined, dual-pronged approach. It should clarify, lichen sclerosus cannot currently be fully cured. But the medical guidelines from organizations like the British Association of Dermatologists are very clear that it can be highly controlled, and the architectural destruction and cancer risks can be halted.
So what's step one?
Step one is absolute mitigation of the Koebner triggers. You have to stop the physical and chemical friction.
So stopping the cycle at the source.
Exactly. The clinical guidelines stress the total elimination of standard soaps, bubble baths, and shower gels because those strip the skin of its natural barriers. Patients are advised to use exclusively soap substitutes and heavy emollients to wash and moisturize.
Gotcha. So you're basically creating an artificial physical barrier of moisture to reduce the friction of daily movement.
That's right. And managing urinary incontinence meticulously is also essential, along with avoiding tight clothing, horseback riding, or prolonged cycling. You must remove the environmental fuel driving the Koebner response.
Yeah, makes total sense.
But step one isn't enough on its own because the immune system is already hyperactivated.
It's already in panic mode.
Yes. So step two requires intervening chemically to force the inflammation to quiet down. We rely on ultra-potent topical corticosteroids,
Right.
specifically one called clobetasol propionate.
Okay, so you bring in the heavy hitters.
Yeah.
Because you can't just moisturize away an autoimmune attack. But using a steroid that powerful seems risky, especially when the skin is already thinning.
It does seem risky.
If the goal is to stop the skin from becoming tissue paper, wouldn't a strong steroid basically make that worse?
That is the exact paradox dermatologists have to manage. Clobetasol is exceptionally potent. Think of it as putting chemical earplugs into the local skin cells.
Chemical earplugs, I like that.
The immune system is constantly sounding a false alarm, screaming at the skin to inflame and attack itself. The steroid blocks that communication, forcing the local immune system to power down so the skin can finally breathe and heal. But because it is so strong, it has to be used with a very specific, evidence-based tapering regimen. Overuse will indeed thin the skin. The dosage instructions in the BSSVD, that's the British Society for the Study of Vulval Disease, their guidelines rely on a metric called a fingertip unit.
I saw that in the guidelines. And it's a wonderfully practical way to measure medicine. How much exactly is a fingertip unit?
It's the amount of ointment squeezed from a standard tube that covers the distance from the tip of an adult's index finger to the first crease.
Oh, okay.
It equates to exactly 0.5 grams of ointment. This ensures the patient applies just enough to suppress the immune response, but not so much that they experience those side effects.
So what's the schedule look like?
The standard induction regimen for a new diagnosis involves applying that one fingertip unit every single night for 4 weeks. This is the acute phase, meant to rapidly shut down the inflammation and break the itch-scratch cycle.
Because stop the itch, you stop the scratching. Stop the scratching, you remove the physical trauma that feeds the Koebner phenomenon.
Exactly, you break the loop. After those first 4 weeks, assuming symptoms have improved, the patient tapers down to applying the ointment on alternate nights for another 4 weeks.
Right.
Finally, they taper to a maintenance dose, usually applying it just twice a week. A single 30-gram tube should last a patient about 12 weeks. The goal is to find the absolute minimum amount of steroid needed to keep the immune system quiet.
Okay, but what happens if the steroid doesn't work? Or if the disease has already caused so much scarring that simply stopping the inflammation isn't enough to restore normal function?
That's where we look at newer interventions.
Yeah, because the clinical papers mention laser therapies being explored, specifically fractional CO2 lasers.
Mm,
And the obvious question here is, wouldn't shooting a highly powerful laser at fragile tissue paper skin cause massive
it
trauma?
really sounds like it would.
Wouldn't that instantly trigger the Koebner response all over again?
It seems entirely counterintuitive, which is why it is strictly performed by specialists. The difference lies in the type of trauma.
How so?
Well, a blunt scratch from a fingernail sends a chaotic panic signal to the upper layer of the skin, the epidermis, which triggers the Koebner response. A fractional CO2 laser, however, creates microscopic, perfectly spaced columns of thermal damage that penetrate past the upper alarm system and go straight into the deeper dermis.
So it's an intentional, highly calculated microtrauma.
Exactly.
It's the difference between like a chaotic earthquake and a controlled demolition. You're bypassing the surface alarm system and talking directly to the tissue underneath.
That's a great way to frame it. You are intentionally triggering the body's healing cascade, but in a precise way that wakes up the fibroblasts. Those are the cells responsible for producing collagen and elastin.
Right, the scaffolding.
Yes. You are commanding them to produce healthy scaffolding
Right.
and revascularize the scarred tissue. And the data in our sources is actually incredibly promising.
Yeah, what did the numbers look like?
One study involving breast cancer survivors who had severe medically induced vulvovaginal atrophy showed that 84% of patients reported a statistically significant improvement in symptoms after a 12-week CO2 laser protocol.
84% is a life-altering improvement for a condition this painful.
It truly is. The studies documented significant regressions in pain during intercourse, dramatic improvements in vaginal moisture and elasticity, and even improvements in urinary urge incontinence.
But there are some caveats, right?
Yes. The NICE guidelines, the National Institute for Health and Care Excellence, they do caution that while the short-term data is excellent, we still need larger, randomized, placebo-controlled trials.
So figure out the long-term stuff.
Exactly, to determine the optimal number of cycles, long-term safety, and whether patients will need continuous retreatment to keep the anatomy functioning.
Okay, let's pull all of this together. We started by looking at the Koebner phenomenon, this terrifying biological glitch, where your immune system interprets a simple scratch or a bit of friction as a command code to build a localized disease. We saw how this phenomenon turns lichen sclerosus, a disease characterized by fragile porcelain-white skin and severe itching, into a vicious, self-fulfilling cycle of destruction that can literally erase normal anatomy.
It's a devastating cycle.
And we learned that the only way out is a rigorous two-pronged attack, physically removing the friction that triggers the Koebner response with emollients, and chemically quieting the immune system with ultra-potent steroids, or, in severe cases, precision laser therapies.
It is a remarkable journey from a microscopic physical trigger to profound anatomical change. But if we pull all the way back, this really leaves us with a profound mystery about the human body that science is still trying to unravel.
What's that?
Well, we know that the Koebner phenomenon happens, right? We can observe it clinically and under a microscope. But why?
Right, the mechanism behind it.
If a systemic autoimmune disease is circulating everywhere in your entire bloodstream, why does it wait for a physical scratch to suddenly manifest in that exact location?
It's so weird to think about.
It suggests that there is a deep, highly complex, and poorly understood communication network happening between the physical trauma on the outside of our skin and the immune cells waiting on the inside. What else is our skin telling our immune system on a daily basis that we simply haven't learned how to hear yet?
That is a wild thought to leave on, just how deeply connected the physics of our environment are to our internal biology. Thank you so much for joining us on this deep dive.
Thanks for having me.
As you go about your day, keep questioning the amazing and sometimes completely baffling ways the human body works. And maybe next time you get an itch, you'll think twice before you give in to the urge to smash it.